And the second speaker needs no introduction as well, I think, is Professor Marlies Ostermann from London. And she will talk about SGLT2 inhibitors and critical illness and the effects on the kidney, I suppose.
Thank you, Peter and Lotta. Yes, I will talk about SGLT2 inhibitors during critical illness and also mention the kidneys. I have no particular conflicts of interest related to this talk. So more and more people are using and are being prescribed SGLT2 inhibitors. Just as a reminder, the kidneys are obviously remarkable organs and they have many duties. One of them is to reabsorb glucose. And about 90% of renal glucose absorption occurs in the S1 segment of the proximal tubule. So when glucose gets absorbed, it gets absorbed together with sodium. SGLT2 inhibitors work by essentially blocking this process. And as you can imagine, then glucose doesn't get reabsorbed and ends up in the urine, resulting in glycosuria. So why would we give SGLT2 inhibitors? Clearly, we reduce the reabsorption of glucose and reduce the serum glucose concentration. And therefore, when they first started, they were introduced as anti-diabetic medications. But it also turns out that they have a beneficial effect on the tubular cells and reduce the workload of the tubular transport system and reduce oxygen consumption. And I'll just show you a picture confirming this. These are the results of a randomized controlled trial in patients, 20 patients who were randomized to an SGLT2 inhibitor versus placebo. And they underwent MRI scanning to look at oxygenation in the cortex and also in the medulla. And here, a lower value corresponds to higher oxygenation. And as you can see here, during this 6-hour period where patients received either an SGLT2 inhibitor or placebo, oxygenation was better in the cortex and also in the medulla, despite the fact that blood flow was unchanged, suggesting that these medications led to reduced oxygen consumption. It now turns out that these medications have positive effects on the kidneys, so reducing oxygen consumption, but also positive effects on erythropoietin production. And as we've now learned, they have other effects on the liver, for instance, and on the cardiovascular system, ultimately leading to some weight loss experienced by the majority of patients and some significant cardiovascular effects. And I go into this in a bit more detail. These are the cardiovascular effects which have been shown to be associated with medication, with SGLT2 inhibitors. Some of them are immediate and acute, but some of them are also longer-term effects, like the reduction in fibrosis. Now, they're obviously concerned about ketoacidosis and the risk of euglycemic ketoacidosis. The exact cause is not clear, not confirmed, but it is thought that this is due to a change in the relationship between insulin and glucagon. Clearly, patients need less insulin if their blood sugar is lower. But this can lead to, as has been shown, to an increase in counter-regulatory hormones, which may increase lipolysis, which is thought to be responsible for weight loss. But this ultimately seems to be also related, linked with ketosis and production of ketones. And it is thought that this is the background and rationale and reason for ketoacidosis, which has been seen with these medications. But overall, the cardiovascular effects are very impressive, confirmed in many studies, and therefore it's not surprising that the European professional societies recommended SGLT2 inhibitors for patients at risk of cardiovascular problems, and also the American College of Cardiology included SGLT2 inhibitors for patients at high risk of cardiovascular problems and for patients with heart failure. And overall, they went further and said that these medications were likely to have an immediate economic benefit. So more and more people, more and more patients are being prescribed these drugs. Do they have a positive effect on kidneys and kidney prognosis, kidney risk? Well, we now have at least 13 trials that looked at progression of kidney disease or risk of acute kidney injury. And again, there's a positive results. Here we have the results looking at progression of existing kidney disease. And as you can see at the bottom, the systematic review concluded that the SGLT2 inhibitors had a positive effect in favor of these medications. And the same was seen for the risk for the reduction in acute kidney injury. Now, the session here is challenges in the intensive care unit. And the question is, how should we handle these medications in critically ill patients? I want to start with acknowledging the fact that the FDA recommends to stop SGLT2 inhibitors in patients undergoing major surgery. And a lot of people have interpreted this as stopping the medications for patients who come to the intensive care unit. Now, would there be a risk, would there be a benefit in starting these medications in patients who come to the intensive care unit, given that they all have majority have cardiovascular problems and the majority are in the intensive care unit for some cardiovascular support? Well, the role of starting SGLT2 inhibitors in critically ill patients was explored in the Defender trial published last year. And this is a large randomized controlled trial in 22 ICUs in Brazil, where patients, adult patients expected to be in the ICU for at least 48 hours with at least one organ failure were randomized to an SGLT2 inhibitor versus placebo. And in this randomized controlled trial, there was no difference in the primary outcome, which was a composite of hospital mortality, starting renal replacement therapy, or length of stay in the ICU. So they were not effective in reducing this composite outcome. They also looked at safety, and as you can see at the bottom, there were a large number of serious adverse events reported, about 45, 46% in both groups, but there was no difference, just showing that patients in the ICU experience a lot of adverse events. And with regards to the feared complication, ketoacidosis, it was not reported in a single patient. So the Defender trial concluded that there was no benefit in starting these medications, but they were safe. So critically ill patients tolerated them, but didn't necessarily benefit from them. That leads to the question, what should we do then with patients who come to the ICU and are on SGLT2 inhibitors chronically for pre-existing heart failure, pre-existing cardiovascular problems? And at the moment, it is advised in many guidelines, also on the background of the FDA warning alert, that these medications get stopped. It is possible that that's the right advice, but it is also possible that we may cause harm. And I'm saying this because the Emperor trial was conducted in the past, looking at the long-term effects of SGLT2 inhibitors in patients who had been prescribed these medications for an obvious clinical reason, cardiovascular problems. And they tested whether the medication effect lasted for beyond discontinuation. So a double-blind trial in patients with heart failure receiving SGLT2 inhibitors versus placebo. And to start with, the patients were randomized to one or the other. And then the medication was stopped. And they analyzed patients who had their medication stopped for at least 30 days. So the placebo was stopped and the SGLT2 inhibitor was stopped. And they noted that in the group of patients who had been randomized to placebo, here in red, there was no difference in their cardiovascular risk. But in patients who had received the SGLT2 inhibitor, the acute discontinuation led to a significant increase in the risk of death or rehospitalization. And the trial concluded that, yes, the effect of SGLT2 inhibitors with heart failure was impressive, but it dissipated rapidly after withdrawal of the drug. And in my mind, this is quite an important trial because it questions this current practice, and we don't know whether it's actually safe and the right thing when we stop these medications either before surgery or in patients coming to the intensive care unit. And Mathieu Legrand and I were asked to explore this recently in an editorial. We obviously looked at the Defender trial, which I already showed you. Also looked at the DARE-19 trial, which was a trial looking at SGLT2 inhibitors in patients with COVID-19 admitted to the ICU. Both trials showed no positive effect with these drugs during critical illness, but they also showed they were safe. And with that in mind, I think we still have to be mindful and question this current practice and the current guidelines, which are obviously based on concern about safety. It has never been tested in critically ill patients whether it's safe or beneficial to stop SGLT2 inhibitors on admission. I think what we can say when patients come to the ICU, and we see more and more patients, given the recommendations in all international guidelines, given the fact that they are beneficial for chronic patients with heart failure and cardiovascular disease, we will see more and more coming to the ICU. I think we can say that it's safe and advised to stop them in those who are very likely to have a high risk of ketoacidosis. So patients with severe shock, patients who don't have any well-established indication, who don't have any cardiovascular risks, and in patients where the drugs are contraindicated anyway. But whether we should consider continuing these drugs in those who were started on these medications for a good clinical cardiovascular indication and don't have any of these immediate contraindications is questionable, and I don't have the answer at the moment. I do know that trials are going on, not looking at discontinuation versus continuing, but there are certainly trials going on in the intensive care unit looking at these drugs in the setting of acute kidney injury and to induce recovery and also to prevent acute kidney injury. So I think this is still an evolving field where much needs to be done, more research is necessary, but we can say at the moment that more and more people are using these drugs, are being prescribed the drugs for very good reasons. Acute withdrawal appears to be associated with an increased risk of deterioration, rapid deterioration within 30 days. The drugs have shown positive effects with regards to kidneys, so prevention of acute kidney injury and prevention of progression, but that's in the relatively stable environment. The Defender trial has given assurance that the drugs are safe in patients with organ dysfunction, but how to handle them in those who need to come to the ICU, whether to stop or not, remains unclear. Thank you for your attention.
Thank you very much. We have time for a short question. Then can I ask you a question? Yes.
Hello, Dr. Ostermann. Thank you for that lovely talk. My name is Danica. I'm an intensivist, and my disclosure is I'm also a clinical pharmacology fellow finishing at the University of Chicago. This is very near and dear to my heart. And I'm wondering if you have thought about or seen in trials where people are actually considering that the pharmacokinetics of our critically ill patients are profoundly deranged. People say GI intolerance, but it's so much more than that. We know when people are volume overloaded, their intestinal permeability is different, their receptors for transporters are grossly deranged. And I think to say we expect these drugs to be effective in our critically ill patients at the doses tested in people with normal, healthy pharmacokinetics is unreasonable. So are people, when they're designing these trials, actually looking at these considerations? Because I would hate for us to throw out the baby with the bathwater because we're not considering these nuances of our patients.
I'm sure you're absolutely right. No, we're not. And I think Danielle Serrano is in the room, and she would say we're also not acknowledging that men and women are different, and we're acknowledging many of the other factors that affect pharmacokinetics and pharmacodynamics. So the answer is no, we're not. We need to be better. So to translate the results of the chronic population to the intensive care population is maybe erroneous.
Yeah,
You're right.
but thank you. I think this is really great work.
Thank you.
Thank you. One more question for me. So coming back to the FDA recommendation, so how would you recommend patients already on SGLT2 inhibitor come in for elective surgery?
So at the moment, the recommendation is to stop the medications. And the guidelines from anesthesia societies also recommend to stop the medications. This has been, certainly in the UK, been transferred to the intensive care unit and the medications get stopped.
Thank you very much.
But it will only change if we find the evidence to convince the FDA and other societies that it's safe.